Good morning, everyone, or good evening. It's evening while I'm recording this, but hopefully you're watching it in the morning. So today's lecture is going to be a continuation of the tumor imaging, and we're going to look at MIBG imaging today. So hopefully you remember from your radiopharm course that MIBG stands for meta-iodobenzoguanidine. And MIBG is an analog of norepinephrine, and it's been proven to be of great value in localizing pheochromocytomas that are found in the adrenal glands, as well as neural crest tumors, such as neuroblastomas and paragangliomas. So I just want to talk very quickly about pheos. So the pheochromocytoma is a neuroendocrine tumor, and it grows from cells known as the chromaffin cells. And these cells are found in the adrenal glands. And pheochromocytomas, or we just call them pheos because it's hard to say, can be life-threatening because these hormones can cause a number of disturbing symptoms, the most serious being related to heart muscle disease and bleeding in the brain, as well as complications in the lungs. You may have heard of, sometimes on the requisitions, it'll say question MEN or MEN2. So these refer to a number of genetic conditions that may be linked to pheochromocytomas. So MEN stands for multiple endocrine neoplasia, and it's a disorder that results in tumors generally in more than one part of the body's endocrine system. And these tumors can appear in the thyroid, parathyroid, lips, tongue, and GI tract. There are a number of other conditions that may be related to pheos as well, but we won't go into those. You may be studying those with Ali. Next, we have the neural crest tumors. And this is probably the most common indication for doing MIBG scans in children. Neuroblastoma is the most common childhood malignancy after leukemia and the primary CNS tumors. So it's the most common extracranial solid cancer in children. And we saw a lot of these at Children's Hospital. About 50% of the kids have METs at the time of diagnosis, which is part of the reason why their prognosis is generally a lot poorer than some of the other childhood malignancies. It is definitely a childhood malignancy, with about more than a third of patients being less than a year old at the time of diagnosis, with a median age of about 17 months. So these neural crest tumors, they are derived, as the name implies, sorry, I'm just going to move this over, from the medulla of the adrenal gland. And these neural crest cells develop, and they can, they sort of transform into a number of different types of cells. See if I can zoom this up a little bit for you. So you can, oops, too far. Sorry, my mouse is very touchy here. This is how the neural crest cells are formed, obviously, during fetal development, and then they migrate and they turn into various types of cells, including the melanocytes, various neural cells, number of endocrine cells, such as those chromaffin cells, as well as mesenchymal cells, including osteocytes. And this is why we can end up with these neural crest type tumors throughout the body, right? So we can end up with those that involve the thyroid, so the medullary thyroid carcinomas, neuroblastomas, which are usually found in the abdomen, and then the PHEOs, which are found in the adrenal glands, and then we can get some along the spinal cord as well, and you can even get these tumors that form melanomas. The cells that arise from the neural crest have this remarkable capacity for motility, invasiveness, proliferation, and pluripotency. And while those are good traits during embryogenesis, these traits can be a liability later in life and can contribute to multiple malignancies as well as metastasis. So certainly MIBG plays an important role in looking for these neuroblastomas. And as we'll see later on in the unit, there may be a role for I-131 MIBG for the treatment of neuroblastomas. Other indications, these more in adults, ganglioneuroblastomas, ganglioneuromas, paragangliomas, carcinoid tumors, as well as the medullary thyroid carcinomas. So just a reminder in case you've forgotten or you haven't been watching your Grey's Anatomy. So norepinephrine is an adrenergic hormone, and it acts to increase blood pressure by causing vasoconstriction. It's synthesized by the adrenal medulla, and it's also available as a drug, right? So it can be created in the lab in the form of levoarterenol. And as those of you that watch these medical shows know that when patients are in crises, they often say that they want a shot of epi, right? And this is usually in patients having an acute hypotensive episode where they need to raise the blood pressure quickly. The term adrenergic means just pertaining to those sympathetic nerve fibers that use the neurotransmitters epinephrine and norepinephrine. So before we get into the actual theory, just a reminder that you can look at the SNMMI Quick Reference Protocol Manual, a section on adrenal imaging. So MIBG, as you know, is labeled with either I-123 or I-131 MIBG. One sec here. And I-123 primarily for diagnostic purposes, I-131 for therapeutic purposes, although in many places in the world that don't have access to high purity I-123, they scan with I-131 MIBG. And I remember, going down to the States frequently, and they were so jealous that we were able to use I-123 MIBG, which obviously has better image characteristics, because down in many parts of the States, they only have access to the I-131 version. So MIBG has been shown to localize in the neurosecretory granule vesicles in these chromaffin cells that contain norepinephrine. And the exact mechanism is relatively well understood. What we know is that it does react similarly to norepinephrine in vitro. So that's why we often refer to it as an epinephrine analog. There are two known mechanisms for uptake of MIBG. One is a sodium-dependent or active transport by the norepinephrine transporters that are found on various cancer cells. And then there's the sodium-independent mechanism, which is by passive diffusion. Just a note here, sometimes it can be confusing because when we talk about NET, you have to know, are we talking about the norepinephrine transporters, or are we talking about the abbreviation for neuroendocrine tumors. So they're related, but they may have a different definition depending on the topic. So I'll let you read this yourself. We kind of went over this when I showed you the picture of the neural crest cells. Oh, I should just mention that once MIBG gets taken up in those neuroendocrine cells, the majority stays within the cells, bound in those neurosecretory vesicles. MIBG is not decomposed by enzymes, and it's not bound to any of the postsynaptic receptors. So it just seems to stay in those neurosecretory granules. MIBG uptake is dependent on catecholamine excretion as well as that adrenergic innervation. At the tissue and cellular level, as I said, most of it remains in the cytoplasm. And the fact that tumor uptake is proportional to the expression of those neurosecretory granules is what can lead to this variable MIBG uptake and the different detection sensitivities depending on the type of tumor. So not all, for example, not all neuroblastomas are MIBG avid, which is why now we are utilizing PET and or things like somatostatin for imaging in patients who have negative MIBG scans. After IV injection, about 50% of the administered dose will appear in the urine by 24 hours, and about 70 to 90% of that residual activity will be excreted within 48 hours. So because there is this significant bladder and urinary tract activity, we should, again, have our patients well hydrated and have them void frequently. MIBG would normally be taken up by the liver, smaller amounts seen in the spleen, lungs, salivary glands, thyroid, skeletal muscles, and the myocardium. And, you know, one of the things that you can think about is sort of that fight and flight mechanism and which organs would be activated in that fight or flight mode, and those often will show up taking up the MIBG. We actually don't see a lot of adrenal gland uptake. Sometimes you can see some faint uptake 48 to 72 hours post-injection, but surprisingly, we don't see a lot of adrenal gland uptake. And then you can see variable degrees of MIBG uptake in the nasal mucosa, brain, lungs, gallbladder, colon, uterus. So a lot of, you know, in terms of the biodistribution, it's not a nice, clean looking scan, which is sometimes one of the downsides of imaging with MIBG. We have to be concerned about free iodine. So if any of the iodine becomes dissociated from the MIBG, it would cause undesirable uptake in the digestive system as well as in the thyroid. And this is why we block the thyroid pre-scan so that if there is any free iodine, it will not localize in the thyroid. And this is particularly important in peds, right? Because the thyroid gland is quite radiosensitive. We should not see a lot of bony uptake in a normal MIBG scan. And you'll sort of see a little bit of an outline of the skeleton, but if we see any increased uptake, whether it be focal or diffuse, this is often a sign of bone marrow involvement or bony metastasis. So if your MIBG scan looks like a bone scan, then that's not a good thing. And then just a note here that sometimes there can be slight differences in biodistribution depending on whether you've used I-123 or I-131 to label. So for example, when we use I-123, we actually see a little bit more hard uptake than if that same patient was scanned with I-131. So in general, just it's important to know which agent was used. You know, sometimes I say when we go to other countries and we're looking at their scans, thinking that perhaps the patient was injected with I-123 and having an expectation of certain biodistribution without realizing that perhaps that patient was actually scanned with I-131. So as I mentioned, in normal MIBG scan, we're going to see uptake in any tissues that are rich in adrenergic innervation, right? So the heart, salivary glands, and the normal adrenals. We'll also see uptake in organs of catabolism. So that includes your liver and your thyroid. And we would see uptake due to the excretory process. So kidney, bladder, and some gut. So if you're having trouble sort of memorizing where you might see MIBG, if you just remember these sort of three categories, it might help you to remember. So the protocol, there's a couple of things that we need to pay attention with MIBG. The first is that they need to be off any uptake it's kind of a weird way of saying, but any medications that might interfere with uptake. And depending on the drug, there is a specified time period that they have to be off these meds. So before you get too worried about having to memorize this whole chart, you don't need to memorize everything that's on this chart, but you should familiarize yourself with the key groups, types of medications, and the more common classes of drugs that are known to interfere. And, again, some of the more common drugs that patients tend to be on. So that's going to include, I'm just going to get my highlighter here for you. Oh, that didn't work, did it? Let's try this instead. Opioids, right? So opioids, cocaine, tramadol, right? These are narcotics. Many patients are on opioids for pain control. And so they can interfere and inhibit uptake. So they should be off these for roughly 7 to 14 days, right? Which may be difficult. Generally speaking, I'm used to the pediatric setting. We didn't have too many cocaine addicts coming in for scans. This may be slightly different though if you're working somewhere like St. Paul's, right? So you may need to determine that whether they've been off of these drugs that may interfere with MIBG. The tricyclic antidepressants, again, very commonly used. Again, they need to be off of these for 7 to 21 days. Sympathocomimetics, so these are things like phenylpropanolamine, pseudoephedrine, salbutamol. The first of these are often found in antihistamines, right? Even over the counter, hay fever meds and cold meds. Salbutamol is a very common inhaler that asthmatics use, right? It's also known as Ventolin. So these are common medications. that are known to deplete those neurosecretory granules. So again, 7 to 14 days off of these. Antihypertensives and cardiovascular drugs. So you'll recognize, these labetalol, metoprolol. These are low pressure. These are blood pressure meds. Also, the calcium channel blockers are quite commonly used. And so these, again, can either inhibit uptake or they may deplete the granules. So again, usually 3 to 4 weeks off of these. The ACE inhibitors, right, captopril and alapril, probably the angiotensin receptor blockers probably as well. These can actually cause increased uptake, so they should be off these for 2 weeks. Antipsychotics, again, we don't see too many patients coming in that are on these, but again, they need to be off them for roughly 3 to 4 weeks. So this is a rather extensive list of drugs. What I will say is that not all departments will necessarily restrict patients from being on these meds, because you can see that they have to be off them for quite a lengthy period of time, which may not be possible without other adverse side effects. So oftentimes we will ask patients what drugs they're on. Some are known to be more problematic than others. And many times we'll go ahead and do the test, and it's only if we see, an altered biodistribution, then we might go back and say, oh, it's probably because they were on a certain medication. So yeah, it'd be nice if we could screen all the patients for these and have them be off them for, 2 to 4 weeks, but sometimes that's not practical. It's also been reported that some foods that contain vanilla and these catecholamine-like compounds may interfere with uptake. So this can include chocolate as well as blue vein cheeses. And these are known to interfere with the uptake due to depletion of granules. So again, maybe you can, tell your patients not to eat chocolate and blue vein cheeses, within a few days of the test. As I said, the thyroid needs to be blocked. So this can be done with either Lugol's, or you can give them potassium perchlorate. So we tended to give potassium perchlorate in the peds, but sometimes that can be quite a large volume to give to adults, and so they may go with the Lugol's. So the dose is 1 drop of Lugol's 3 times a day, beginning 1 to 2 days before the MIBG injection, and then continuing for 3 days post MIBG. If you're using I-123, you need to continue those drops for 2 weeks post injection if you're using I-131. Some sites may use potassium iodide tablets instead of Lugol's, or in the case of peds, we used the potassium perchlorate. So patient prep is important. When it comes to giving the injection, the key thing here is that we need to administer MIBG slowly. Okay, so it's given intravenously, but it's given very slowly, and it's, whenever possible, you want to give it into a peripheral vein. So you might ask why that's important. Well, again, remember that this is a norepinephrine analog. So if you were to give it as a very quick bolus, there may be some adverse effects to giving it quickly. And that can include severe hypertension, right? So we want to give it very slowly. The reason for giving it into the peripheral vein, again, is so that it has time to mix with the circulating blood before it reaches the heart, as opposed to giving it in a central line where it's dumped right into the heart. And again, it may cause some adverse effects and unpleasant symptoms in the patient. So these adverse effects can still be seen even with a slow injection, but they, less likely to occur and maybe a slower onset. So this can include hypertension, tachycardia, pallor, vomiting, and abdominal pain. And I can tell you, having done a lot of these injections, that it was not uncommon to see these signs and symptoms even when we injected slowly. We used to have patients that needed these tests done on a regular basis, and we had this one boy, and so after the first injection, he would never eat before coming for the injection, because every single time we'd give him the injection, even as slow as we would give it, he would always throw up. And oftentimes you can almost know the second that the MIBG enters into their bloodstream, because they start to, their heart starts to race, they start to sweat, right? They start to feel unwell. Sometimes we used to think, oh, it's just, psychosomatic. But after doing this multiple times, we realize that, even if they're not watching us while we're giving the injection, they have these reactions. So rapid injection is always contraindicated because it's likely to induce these undesirable side effects. Now, the side effects seem to be more common in pediatric patients. As I said, invariably, most patients that we injected would have some types of symptoms. And at first we thought it was sort of an adverse reaction. We actually had a conversation with the radiopharmacist at VGH, who was preparing the MIBG for us at the time. What we were told is that when they make up the MIBG, they alter the amount of radioactivity that they label to the MIBG, but the actual amount of MIBG that they attach the label to stays constant. In other words, pound for pound, a pediatric patient is getting way more MIBG per kilogram than an adult. Another way to look at this is that a pediatric patient gets the same amount of MIBG as, say, a 200-pound patient, right? So not only does the radioactivity change, but the ratio of MIBG to patient weight in the case of peds goes up. So we had the conversation with them as to whether or not they would consider scaling down the MIBG dose in addition to scaling down the radioactive dose. And they didn't want to do this because the chemistry is a little touchy. And of course, the protocol is based on, X milligrams of MIBG. And so we just have to be careful when we're injecting to know that they're getting a lot more MIBG per kilogram than in an adult. And as I said, we want to avoid using those central lines whenever possible, partly because, as I say, it dumps the dose directly into the heart, which increases the likelihood of side effects. But the other problem, as you know, when you're using these central venous lines, is sometimes there can be hang up in the lines or in the reservoirs, and if we're looking for uptake in the mediastinum, it can really interfere with our image quality. So you don't need to have a large gauge needle to give this injection. So usually we can find a peripheral vein without any problem. Standard dose for I-131 is 18.5 to 37 megabecquerels. I-123, we can increase that significantly to a maximum dose of 370. Okay, so moving on to the imaging. Imaging should be done routinely at 24 and 48 hours post-injection. If you're using I-131, the whole body scan speed is 4 centimeters per second, which is very slow because we don't inject a lot of activity. Or you can do anterior, posterior, limited field or static spot views, head, neck, chest, abdomen, pelvis, arms, lower extremities. Similarly, if you're using I-123, scan speed's still slow, but a little bit faster than I-131. And we'll try to acquire more than 250,000 counts. Again, either in whole body mode, or you can do static planar views. It almost inevitably is a whole body scan because we're usually looking for the primary tumor plus the possibility of metastatic spread. But you may want to do, zoomed, high resolution, high count rate images over the area where they suspect that the actual primary tumor is. One of the advantages of using I-131 is that it does allow you to go beyond 48 hours with your delayed imaging, which may be necessary. Sometimes these tumors can take a while to localize the tracer. With I-123, you really can't go much beyond 48 hours. And as I said, planar plus or minus SPECT CT. So I have a question for you. What collimator do you think we should use when we're scanning I-123 MIBG? So I'll let you think about that for a sec. And I'm going to wager that the vast majority of you said that we should use a low energy, high resolution collimator, which is great because that kind of makes sense, right? I-123 has an energy of 159 kV and we want high resolution. So we should use a low energy, high res collimator. And for many years, that's what people did. But recently, this article was published in the JNM, and it talked about using a medium energy collimator instead of a low energy collimator. People thought, what? Why would we want to do that? And it turns out that the medium energy collimator actually gives superior resolution. So this is a JZAC, one of the cuts through the JZAC. And I think you would agree that there's better resolution. We can see more of the small spheres with the medium energy than we can with the low energy. And if you look at the actual image, I would challenge you to disagree that this image with the medium energy collimator is not sharper than that taken with the low energy collimator. So why is this? Well, it comes down to this high energy photon that is given out by I-123. And the thought is that because it can penetrate through the low energy collimator, that it degrades the quality of the image. So depending on where you are, don't be surprised if they actually use a medium energy collimator for their imaging. Okay, so here's a diagram that shows you the normal MIBG scan. So again, turn my pointer on. Hold on one sec. So you can see lots of uptake in the liver, right? And then we've got some kidney, we've got some bladder, we've got salivary glands, we've got a little bit of thyroid, which means that maybe they weren't blocked as well as we would like. You can see a little bit of faint uptake in the lungs. The uptake in the heart is variable. You know, we don't really see the skeleton, right? You kind of can faintly make out where the bones are, but this should not look like a bone scan, okay? So here's a couple of abnormal studies. This is a pheochromocytoma. You wouldn't miss it. You know, the resolution's not great, but it's clear that there's this focal uptake in the region of the adrenal gland, and this was actually a pheo. Here's a 4-year-old boy, left adrenal tumor that was seen on a CT scan. They did a biopsy which showed a poorly differentiated neuroblastoma. And unfortunately, like so many patients that we see at the time of diagnosis, he's already got widespread metastatic disease. Right. So if you're seeing bones, as we are here, right, this is not a good sign. So just want to talk a little bit about MIBG therapy. You know, we started off using I-131 MIBG and I-123 MIBG for diagnostic purposes. And eventually somebody said, well, if we can use it for diagnostic purposes, why not try to use it for therapeutic purposes? And the MIBG has about a 5-year survival in about 80% of infants. For older children, the survival pre-1985 was only about 40%. It's risen to greater than 65% since the last 20 years or so. But it's still a devastating disease, and patients often succumb to disease. And part of that, the reason is that it's very resistant to treatment. And so the thought was, why don't we try radioisotope treatment? And it has been used to treat very specific tumors, including patients with inoperable pheos and paragangliomas, some carcinoid tumors, stage 3 and 4 neuroblastoma, and metastatic or recurrent medullary thyroid cancer. Generally speaking, most of the patients we used to see in peds were already a stage 4 neuroblastoma at the time of diagnosis. Again, the disease is widespread at that point. And so in a sense, trying I-131 treatment was kind of a last resort. But there was usually, they'd failed multiple rounds of chemo, and there was really no other treatment left to consider. So many of the patients opted to try I-131 MIBG treatment. And it was first used back in 1986, and there's been a number of trials using I-131 MIBG since then. In Canada, the Cross Cancer Institute in Edmonton was a leader in MIBG therapy. Actually, throughout the world, Dr. Sandy McEwen is considered sort of the expert on I-131 MIBG treatment. So if you ever get to the SNMMI, he usually gives a talk every year. And I recommend that you go and listen to him, because he's got a lot of knowledge and a lot of years of experience behind him. And he was the first to sort of propose using I-131 MIBG for treatment, particularly in peds. And for a long time, we at BC Children's, we used to send our patients to Alberta to be treated. And now the new Children's Hospital has a specific radioisotope treatment room. Some of you, if you've been to Children's, may have had the opportunity to check it out. If you don't, when you go there, maybe ask one of the techs if they can show you the room, because it was specifically designed for doing things like I-131 MIBG treatment. So the standard dose, well, I shouldn't say standard dose because there really is not a standard dose. In adults, it can range from 3.7 gigabecquerels, right? That's a lot. And this is even more, 11.2 gigabecquerels, right? Remember, I think what was the dose that we were giving? 37 megabecquerels for imaging, and we're giving up to 11 gigabecquerels for treatment. And this is given in less than 6 milligrams of MIBG. It's given via slow IV infusion, anywhere from 45 to 4 hours. So as I said, there's not really a standard dose. They can actually give much higher doses, and they often do. Remember, most of these patients are sort of end stage disease anyhow. And as long as their bone marrow stem cell support is available, and their cell counts are adequate, they can continue to give higher doses. Obviously, the thyroid has to be blocked throughout this time, because otherwise the treatment's just going to go and ablate the thyroid gland. So you might say, well, how successful has this been? And the results have been encouraging, with over 50% of patients reporting either objective or subjective improvement. So while it's not necessarily going to cure them, it may prolong their life, or at least give them a better quality of life. And they've shown that even low doses can provide significant and immediate pain relief, often within 24 hours. Patients can have multiple treatments. Many have 5 to 11 treatments, and they just keep on giving them more until it's no longer effective. And so you can see the stats here. Most patients get 4 to 5 treatments. Average dose of each is about 6 gigabecs. And according to Dr. McEwen, the maximum dose is 58,000 megabecquerels. But they have one patient who has received, what's that going to be, 13 gigabecquerels total dose, which is a huge dose. But, it seems to work. And as long as it continues to give the patient relief, they will continue to treat them. Obviously, there are side effects. Early side effects include nausea, vomiting. There may be some myelosuppression. Kidney adverse effects are rare. They could have a hypertensive crisis because of that release of catecholamines when the gland is affected, but it does seem to be relatively rare. There are late effects, including hypothyroidism, particularly if the thyroid gland is not adequately blocked during treatment. Again, persistent thrombocytopenia, myelosuppression. And unfortunately, like so many of the treatments that we give involving radiation, it may cause leukemia or a secondary tumor. But as I say, usually in my experience, these patients are sort of end stage disease, and at that point, we're not worried about them developing a tumor 20, 30 years down the road. We're just trying to prolong their life, for the next year or so. So here's a couple of images that talk about the future of MIBG imaging. So here's an MIBG scan. These first two images are done with I-123 MIBG. And if you look closely, you can see where the arrows are pointing that there may be some involvement in the femoral areas. This third image was actually done with a compound known as fluorine F18 MFBG, which is metafluorobenzoguanidine. And this is a PET equivalent of MIBG. And I think you could see that it's superior in terms of its localization of some of the lesions in this patient. So we may be replacing, just as PET replaced standard MIBG, FDG, PET, and F-DOPA PET, perhaps FMFBG is the future of, I guess we can't really call it MIBG imaging, but neuroendocrine imaging. Oh, come on. I only have one little bit left to go. And things are frozen. Sorry, guys, hold on. I don't know why it freezes up. Here is a patient, a 12-year-old with neuroblastoma. The first images here were done pre-therapy. So I-123 done pre-therapy, showing multiple foci of uptake consistent with lesions in the skull, the right humerus, vertebrae, and pelvic area, as well as in the right tibia. The patient was treated with 21.8 gigabecs of I-131, and a post-therapy scan was done. And I think you would agree that the lesions have all disappeared, right? So as I say, there does seem to be some promise with the use of I-131 MIBG. We don't treat a lot of patients. So it's taking a while for us to figure out what's the best dose, what's the best treatment regimen. Do we give it with chemo? Do we give it before chemo, with chemo, after chemo? Do we do it with a stem cell transplant? So there's a lot of factors and variables that need to be worked out. It's all part of the clinical trials. I have posted the EANM guidelines for MIBG therapy onto the Learning Hub for those of you that may have an interest. And as I say, you may be fortunate enough to get to see an MIBG therapy during your rotation at Children's Hospital. So if you do, it'd be great if you could maybe present it as a case study, just because they don't come along all that often. So that's the end of the MIBG unit. You'll note that there is an appendix that deals with other nuclear medicine adrenal imaging applications, but these are for clinical reference only. They are not tested on the CMRT competency profile, and I will not be testing them in the NMET 3025 course. But if you need to refer to them for other clinical reasons, the note package is there for you. All right, so that's it for MIBG, and good luck with the case studies, and happy to answer any questions when we meet up again in person.